Welcome to the campus of North Idaho College and this evening's broadcast of the North Idaho College Public Forum. The crew is comprised of North Idaho College television students. Your moderator is North Idaho College political scientist Tony Stewart.
This evening we're going to be dealing with one of the more serious topics among the human race today. Our subject is cancer. During the next 60 minutes, it is our hope to deal with this subject in at least 4 basic areas. First of all, we will briefly talk about the historical aspects of cancer, or how long it's been around. Secondly, we will spend far more time dealing with definitions of types of cancer and terms in relation to treatment, and especially emphasize the causes of cancer as it is known at this time. The third area will deal with the cures, or the research that's being done at this time in attempting different methods of curing different types of cancer. We shall also discuss the symptoms so that individuals may know when it would be wise to consult with a physician. And finally, we hope to talk a little bit about the future of eliminating this terrible disease. In order to accomplish these 4 areas or tasks of the question of cancer, we are very privileged this evening to have with us 2 physicians from Spokane. They both are associated with the Rockwood Clinic in Spokane and are our guests this evening. First of all is Dr. John Phillips. He is a graduate of Columbia University in New York City, graduating from the Columbia College of Physicians and Surgeons. Also accompanying him this evening is Dr. Kenneth Kramer, also with the Rockwood Clinic, and graduated with his degree from the University of Michigan. Dr. Kramer has been practicing for about 1 year in Spokane, and Dr. Phillips for the past 15 years. Gentlemen, it's a pleasure having you on our program.
Thank you. Thank you.
Joining with me in questioning our 2 distinguished guests are 2 regular members of our panel. First of all is Janelle Burke. She holds a bachelor's degree from the College of Idaho and a master's from the University of Indiana. Welcome, Janelle.
Thank you, Tony.
Our second panel member is Mary Lou Reed, holding a baccalaureate degree from Mills College and did her graduate work in religion at Columbia University in New York City. We shall proceed to questions at once, and the first series this evening will come from Janelle Burke.
Dr. Phillips, sometimes we tend to think of cancer as a phenomenon of recent times. Is cancer new, and is it on the increase?
Well, to answer your first question, no, it's not new. And to answer the second question, it is probably on the increase in the overall picture, yes. It's been here for a long time, but only since our knowledge of medicine has developed have we realized how much cancer existed at the present time. You have to remember that we didn't invent the microscope very long ago, and until the pathologist, the doctor who looks at tissues of the body under the microscope, until they came into the picture, there is very little known about the human body and tumors or growths. They were treated very casually because our knowledge was very poor as little as 100 years ago.
What is cancer? How do you define cancer, or what do you consider the disease of cancer?
Well, first of all, there are many forms of cancer, and but I suppose a good general description of cancer is an abnormal growth of cells that don't behave properly or don't behave like other human tissue behaves.
What is benign and what is malignant? When a person goes to the doctor and they have a bump and the doctor says that's benign, what does that mean?
A benign tumor has no serious implication, and it is not a cancer. It can be many things, but it is definitely not a cancer, and it is something that is regarded without a great deal of concern. Malignancy is just a general term for the that we use in dealing with cancer, whether a tissue, a tumor, or something is malignant, and malignancy is another term for cancer.
What is a tumor?
Excuse me?
What is a tumor?
I was just like to say that there's a difference between being histologically malignant and malignant by position. In other words, under the microscope it can look perfectly fine. It can look like there should be no problem, but if it's located in your brain or your heart, then it's malignant because it's going to do you some damage. That's a little different concept.
What is a tumor? Either doctor.
Fine. Ken, why don't you feel that?
Tumor just means a growth, a lump, and it doesn't tell you anything about what it is, why it's there, or what it's likely to do. And if you bump yourself and a little blood creeps out under the skin, it can be a tumor, it can be a lump. Most people use the term in conjunction with a neoplasm, a new growth of tissue, not related to such minor things like bumping yourself or trauma.
Is cancer usually associated with a change in cells? A change in the way the cell looks?
Very definitely. There are histological criteria that we use to define what is a malignant cell. It sounds very easy, but sometimes it's very, very difficult. There are several things which we don't need to get into that are very specific that we look for as the sine qua non, but nothing is really a pure definition when you look through the microscope. It still is a certain amount of judgment.
Marie.
Well, can I follow along this line of thinking? And I have a list of words that I find very difficult. The hardest one that I have is metastasize. It's hard to say. I think it's a little bit hard to understand, too. What happens when a cancer metastasizes? Metastasizes.
You got it right there.
Either one of you.
Well, it just means that the cancer, which perhaps developed in one part of the body, spread and went elsewhere. And it can spread, say, from the little finger to a lymph gland underneath the arm, or it can spread to the lung. Usually spreads by way of the bloodstream, but sometimes it spreads other ways and through the lymph channels into the lymph glands. So simply said, it's that the cancer that originated in one area spread to another area.
Dr. Kramer, do you want to add to that?
No, I think
that's really the definition. Do you
it.
have ways of preventing this from happening? Are there cautions that you take normally to avoid the cancer spreading?
Sometimes there are things that we do to try and prevent that. Depends on which tumor you're talking to, but such things as radiating the field after surgery, putting chemotherapy in locally at the time of surgery, tying off certain blood vessels, trying to get a tumor out intact without rupturing it and letting the cells spill into the rest of the body. It really depends on what kind of tumor.
Kinds of care. You mentioned chemotherapy, and as I understand it, you're both internists and you practice chemotherapy rather than surgery. Other surgeons take care of that. Would you really, everybody hears about chemotherapy, but I don't think everybody really understands what the limits are. Is chemotherapy just the use of drugs to treat cancer?
That's exactly what it is. There are certain groups of drugs that have been tried in animals, found to be effective, and then tried in humans, found to be effective. Careful trials, usually randomized populations in small groups, and everything looks good, and then we try them on big populations. And there are certain ones that have been around for a long time and certain ones that are brand new and experimental. So we're the fellows who give the drugs.
Okay. To sort of complete this list, perhaps you can volunteer with some kinds of cancer that people may have heard about but may not necessarily know for sure what that cancer is. You want to start, Dr. Kramer, and then maybe Dr. Phillips would add to that list.
Well, the most common cancer in the United States, if you take men and women together, is colon or large bowel cancer. And if you separate men from women and say what's the most common in man and in men, it would be lung cancer. You say what's the most common in women, it would be breast cancer. But taking the two together, we're talking about colon cancer, and we're talking about 100,000 new cases a year. So that's a fairly common disease.
Maybe you could add some of the exotics that that may be a little bit puzzling to us. I have this osteosarcoma mentioned earlier.
Okay, that's a bone cancer, and most common in children, and I believe that Senator Kennedy's son had an osteosarcoma, and he had his leg amputated, and then he got 1 year or more of chemotherapy. He's doing fine, and we're seeing better results in terms of treatment of this particular osteogenic sarcoma. now. Many people have heard of leukemia, of course, and the treatment of leukemia, well, really, chemotherapy, I'm sure we'll get into this in more detail later, but there's only been in existence for since World War II, which was, of course, ended in 1946 or 45, and but the most intensive past about the last 15 years is really when chemotherapy has become more effective in other types of cancers other than leukemia. The other types of cancer that are fairly common, Ken mentioned, of course, breast cancer in women and lung cancer in men by far and away. Breast cancer, bowel cancer, and lung cancer represent the most number of cancers, I'd say, in terms of numbers.
Well, technically, skin cancer is number one, but we think of those as totally separate from the others because histologically they're cancer, but their prognosis is so good that we just consider them a whole
You just
separate disease.
don't consider it as serious because it is curable.
It's highly curable, and it's very slow growing, causes some morbidity if you let it go long enough, but very little mortality. And most cancer statistics that you'll read will always have a little asterisk saying not including skin cancer.
What is the difference between morbidity and mortality?
Morbidity just means that it causes some problem, some disease, some discomfort, but doesn't kill the patient.
And we all know what
Mortality.
Yeah. Thank you.
I'd like to see this one step further. We have mentioned the major types of cancer, but I don't believe we've exhausted the list. Two more come to mind. I would like to, before we move into more depth on certain more serious types, is to try to exhaust the list. I don't believe we've mentioned stomach cancer or brain tumors and so forth. What else is on the list is what I'm asking that we've not covered.
Well, of course, you mentioned those two. Stomach cancer is one of the few cancers in the United States that seems to be on the slight decline. Almost all other cancers are increasing in number, due to many factors maybe, and we might be able to go into more detail on that. Brain tumors, of course, are existent, and they have. A lot of people, there's a lot of talk now of Hodgkin's disease and other types of lymphomas or lymph node cancer, and they have been more prominent in the news in the past few years because our treatments for this have been much more effective, and so that we certainly are encouraged by the results of some of the treatments for these particular types of cancers. There's prostate cancer, there's cancer of every tissue of the body. They're not as frequent as the ones that we've mentioned, but by the same token, there's cancer. So cancer involves many, many, many tissues, and the possible causes of these may be different under different circumstances and depending on where the cancer develops.
I think a good way to break it down would be into what we call adenocarcinomas, which are tumors of glands. And those would be the bowel, breast, prostate, glandular tissue. Pancreas is another one that's very common. Then we have sarcomas, or soft tissue solid tumors. And those are the bone cancers, osteogenic sarcoma, rhabdomyosarcomas. They have all kinds of funny names. And then we have the leukemia and lymphoma group, which are the fluid or liquid tumors, blood and lymph glands.
Some of our questions, I'm sure you will label as rather naive, being laymen on this end of the table today. But is it not also correct that we can break those down further? For example, leukemia, that when you are labeling the different types, that there are different types of leukemia. Is it not correct that some are very, very terminal in a very short period of time, and others are over a longer period of time and are not as fatal? Is that correct? Could you go into a little more detail there to inform our viewers that there are different types within? Let's take leukemia, for example.
Well, go ahead, Ken.
Well, we classify them into acute and chronic, and then into the type of cell involved. So we really have four basic types: acute lymphocytic, acute myelocytic, chronic lymphocytic and chronic myelocytic. And when we talk about the acute, we're talking about the more dangerous, the more higher mortality rate, and the one that gets most of the press. The chronic leukemias usually go over periods of years and don't require as vigorous treatment.
Do they attack based upon sex or age, such as you've mentioned that lung cancer is men and breast, women? How about the leukemia in relation to sex and age?
The childhood leukemia, and the more common childhood leukemia is acute lymphoblastic.
And I'm definitely not stepping on because I've been cautious. I'm going to put that over there. Dr. Phillips, now that we've gone down the list of types of cancer in different parts of the body, and then you've been discussing leukemia, I was wondering if the same holds true in other types of cancer where you mentioned that men more commonly have lung cancer, women breast cancer. How about the different types of leukemia? Does it affect by age and by sex?
Well, as Ken had mentioned, there are acute and chronic leukemias. I think the most marked difference is are those in children. The acute leukemia in children has been very popularized by the press because this again has been one in which there's been a great deal of success in curing leukemia. Leukemia has a terrible implication to everyone, and there's a type of leukemia in adults, chronic lymphocytic leukemia, where the patient may not be treated for years. We've been following a patient in my office I haven't myself personally, but he's had it for at least 17 years and has had no treatment. And yet he does definitely have chronic lymphocytic leukemia. So it can be a relatively benign process. The acute leukemia in adults is more serious than in the acute leukemia in children in terms of results. We're not as successful in treating adults with acute leukemia as we are with children. And hopefully that this is going to improve. It has improved, and the outlook now is more favorable than it was 5 years ago. But we have a long way to go on that.
Thank you. Janelle Burke.
Sometimes when we go to the doctor, one of the questions we are asked is, does a close relative have a certain list of diseases, and one of those might be cancer, or have you ever had cancer? Why does the doctor ask that question? What does this have to do with the diagnosis of my illness? Is cancer hereditary, or if I've had it once, might I have it again?
That's a loaded question. Go ahead, Ken.
You asked a lot of questions there. We don't think of cancers as being hereditary in the true sense of the word, but they certainly are familial. In other words, you may not pass along a given gene, with few exceptions, but cancers tend to run in families. And certainly if your mother has breast cancer, you have a much higher incidence of breast cancer than a woman of equal age whose mother did not. So these are the things we're looking for. There are certain genetic traits which are passed down, particularly cancer of the large bowel associated with a lot of polyps in the colon. There's a definite Mendelian pattern, and the doctor may just pick that up by asking these questions. If you tell him that 3 out of 4 siblings and 3 uncles and 2 aunts had the same kind of cancer, that's very suspicious. The other thing is, once you've had one cancer, you're more likely to have another one.
Does this have to do with type of skin and type of body that you have and your reaction to the environment?
It may or may not. We don't understand that. It probably has more to do with your immune system and the way your body surveys your cells and gets rid of the ones that aren't behaving properly. And it looks as though if there's something wrong with your immune system that allows one tumor to grow, you're likely to have trouble in other areas.
Lou Reed.
Well, following up on the causes of cancer, the 6th annual report of the Council on Environmental Quality said that scientists now estimate that 90% of all cancer is related to environmental factors. First of all, would you consider that a high level? Do you feel that 90% of the cancers actually are caused by environmental factors? Starting with you, Dr. Kramer.
Again, I think you have to define terms a little bit more. If you're talking about total number of cases, then that may be an accurate statement. If you're talking about 90% of the types of cancer, that's probably too high. What I mean by that is, when you look at lung cancer, which is environmentally related, both with cigarettes and pollution, and industrial exposures, that certainly accounts for a lot of cancer. So if you look at the total number of cancers in the United States, right there with one disease, you've got a lot of disease. If you're looking at the different types of cancer, I think that's probably a little too high. In other words, if you're talking about some of the more esoteric cancers, the rarer ones, they may or may not be environmentally related. A lot of work has to be done on that, and the data is just not available.
Yeah, I just have to assume that they probably are talking about 60% of the incidence of cancer, not necessarily of the types. Dr. Phillips, I was surprised when I read that the percentage was that high, because what other places I had read was between 60 and 85%. Does the 90% figure, are you comfortable with that?
No, I'm not. But again, I have to agree with Ken. There may be certain factors, and we know especially about lung cancer, and that's a very, very popular cancer in the United States. And certainly environmental factors are extremely important. But we also have to add in that other element in the individual and how he, as Ken said, surveys his cells that are not growing properly or behaving properly in his body. If you were to take, we don't know enough about environmental factors. Like leukemia, there are 20,000 cases of childhood leukemia alone developing in the United States, but we don't know what environmental factors are involved there. So that there, in too many types of cancer, we just don't know whether there are environmental factors. So I would tend to question that. Well, he may be right, but he's not basing it on all the information available.
Well, this, as I say, this was the Council on Environmental Quality, and they would be perhaps more aware of the environmental factors than perhaps someone more clinically involved, or some group more clinically involved. Even if it were only 75%, does this not lead you to think that perhaps 75% of the money spent on cancer should be spent on prevention and on eliminating environmental irritants rather than the continual search for the cure? That's also a loaded question to be asking doctors. Who wants to take it?
If we knew how to prevent it, I'd certainly go along with it, because when you really think about it, what medicine has done is preventing catastrophic disease, the huge plagues that we no longer have. It probably, I suppose, The indoor plumbing is probably the best preventative medicine effort that has ever been made to prevent the spread of disease. So that it would be very nice if we could create an environment whereby you don't get cancer, and we do know that if you don't smoke, the incidence of cancer is markedly decreased. But you have to eat, and for example, Japan has a much higher incidence of cancer of the stomach than we do. And by the same token, we have a much higher incidence of cancer of the lower intestine than the Japanese do. So what do we eat, and how are the environmentalists going to control that? So there are too many questions here that don't have answers. I fully agree that if we could prevent pollution and prevent smoking, that we'd make a great deal of headway in the reduction of lung cancer. I don't think we do it entirely, but we certainly go a long way.
If I may, Tony, I'll just continue on for one more instant here to suggest that maybe this is time to mention the American Cancer Society, because certainly the American Cancer Society, as I understand it, has taken the forefront in the attempt to discourage people from smoking. Is this not correct?
They have done it.
And do you feel that they have done a good job?
Tough question. I think the number of people smoking in the United States today would indicate that they haven't done a good enough job. But I'm not sure I can say that it's from lack of effort. I just don't think we understand how we can turn people off to smoking.
Yeah, that's probably unfair, because I think we would all agree that they have done a valiant job. I guess the question is
Right.
better put. Is it possible to convince people through advertising that they perhaps should not be harming themselves?
I don't think it's possible through advertising. I think one of the ways that you're going to have to do it is to actually show people what happens to lungs, to their bodies, even if necessary, show them autopsy samples. The only people that I know that have really opened their eyes and thrown the pack of cigarettes down the drain have been people who have seen somebody with emphysema, with a cancerous lung, something much more vivid than an ad saying, please don't smoke, it's bad for you.
I might add that I don't think there's any question. I think there are less doctors smoking now than there were 10 years ago. And I don't have any accurate statistics on that, but I certainly, at the various meetings that I've gone to where there are 300 or 400 people in a room, there used to be smoke-filled rooms 10 years ago. Now they're pretty clear. There are very few doctors who are smoking. Some of them still smoke, but they're much less than they were 10 years ago. So I think that the research has shown something, and I think the doctors have learned, which I'm glad to see.
At the risk of being repetitious, I want to take this one step further, what Lou is talking about. We are bombarded, I guess one can say, with information on television from the government and from private institutions of research and organizations telling us the dangers of cancer in relation to what's causing it. We're told that cigarette smoking is harmful. We're told there are many chemicals in the food, certain types of food that may be harmful. Both food and drugs are often taken off the market, or other items in spray and so forth. We're also told that air pollution is a cause. What I'm trying to get at before we leave this and go to another aspect of our discussion today is, if there is a citizen out there who's terribly concerned with cancer and they're really trying to be a conscientious citizen for their own health and their family and their future, what are they going to do? In asking my question, I'm really saying, is there apparently many reasons for cancer of different types? And secondly, what can a person do to try to be self-preventative by avoiding certain things?
Don't smoke.
Well, certainly I think the data is pretty good that if everyone in the United States stopped smoking, that would be the greatest impact on the treatment of cancer in all time, including every drug and every doctor that's ever treated cancer, which tells you something about the magnitude of the problem. Certainly people who do smoke should stop. People who have never smoked should never start. Other than that, we're talking about industrial exposures to known carcinogens, certain petrochemicals, organic compounds that we know, like benzene for leukemia and other blood-related disorders, avoid those things. We know so very little about interactions of various chemicals and why one person exposed to a certain drug gets the disease and the other one doesn't. I think we've got a long way to go in industry in identifying carcinogens and how we can prevent them. But as to the average person who doesn't work around those chemicals, I think cigarette smoking is about the only thing that they can really avoid themselves.
I do want to ask one more question that came to mind. A few years ago, we seemed to hear more than we do today about the various viruses and their attack on people and how that may break down the cells in a certain way and contribute to cancer. What's your viewpoint in relation to viruses? I know there's many of them and a lot of things we don't know about them, but is this also a possible cause of cancer, Dr. Phillips?
Well, it's certainly a possible cause of cancer, and they've demonstrated in animals that viruses can cause cancer. And this has been done experimentally and proved time and time again. But it has not been demonstrated in human beings at the present time.
Thank you. Janelle Berg.
Dr. Phillips, beginning with Dr. Phillips, and then Dr. Kramer, if you would fill in. What are the symptoms that indicate that I should consult a doctor when I have certain things that I notice about myself? When should I consult a doctor in order that I might prevent a more serious cancer?
Well, the American Cancer Society has put out a leaflet saying the 7 signs of cancer, and I must confess, if I don't get up to 7, maybe Ken can help me. But any kind of unexplained weight loss, unexplained fever, unexplained loss of appetite, any sore on the skin that doesn't heal soon or quickly, any unexplained bleeding from any site that persists, any change in bowel habits. These are the things that have to be looked into. And certainly any lump has to be looked into that is growing. Now, it doesn't mean that it's going to be cancer, but by the same token, any lump anywhere, and of course in women especially, lump in the breast has to be evaluated quickly. And so that the sooner the better. It may be something that the doctor isn't particularly concerned about at the time that you see him, but he says, well, let's look at it in 2 weeks, and he'll have a better understanding as to what the implications are.
Dr. Kramer, sometimes we fear going when we discover one of these things, and we think if we could just put it off. But what are the advantages to going immediately for treatment? And what kinds of prognosis, how much better is the prognosis if we go immediately and if we catch these things earlier than it is if we leave them hoping that they'll go away?
All forms of cancer are treated best when the amount of disease is small. That's a general rule. The lower the tumor burden, as we call it, the more effective is treatment. And this is true whether we're talking about surgery, radiation, or chemotherapy, which are the 3 main modalities of treatment. So if we can pick up the disease early, remove it by whatever means, chances of metastasis and chance of recurrence are at their lowest. The earliest, the better.
Are there any unusual symptoms that we should look for in prevention of child cancer? Are there any symptoms that are different than the ones you have just mentioned? What are the primary ones? Would weight loss be one of the primary ones, or failure to thrive be one of the primary ones to look for in a child?
I would think so.
And bruises, perhaps? Unusual
definitely
bruises?
Increased bruising or bleeding of any type. I fully agree with Dr. Kramer about the earlier you get the disease, the better. There are certain diseases, however, where it may take as long as 2 to 3 weeks to fully evaluate the extent of the cancer. And that time is not of essence in some of these cases, what I mean to say, a week or 2 or 3 while the patient is being evaluated. So that a day, it is not an emergency in that if we don't get it today and don't operate today, then all is lost. We don't mean to imply that. but it's a good general rule. The sooner you see your doctor, the better.
Now, there are some things that I can do to help prevent to help prevent cancer, even though I may not notice any of the symptoms that you are talking about. For example, the yearly checkup, the pap smear, regular checkups to determine if there are possibilities of cancer. What other kinds of things would you suggest, and how often do you recommend the pap smear? And for what ages?
For a woman who still has her cervix, in other words, it hasn't been surgically removed, certainly every year. And for a woman who has had an abnormal pap smear, it should be even more frequent, and that should be left up to the physician as to how often she should get it checked. Usually we would say 3-6 months, something like that. Cervical cancer doesn't change that rapidly, so a few months is fine. Depends on how abnormal the pap smear is. A woman who has had her cervix out or her uterus should still have a pap smear because there are diseases in the vagina that can be picked up by pap smear even after surgery. Many people don't appreciate that fact. And I would say every 2 or 3 years for a woman who's had a hysterectomy. Breast self-examination is key. Most lumps are found by women, not by the doctor. And it's important that you get into the habit of doing it after each shower, or after your period at least once a month, and following the lumps along. Some women have just myriads of lumps in their breasts, and it's very difficult. And those are the ones that are going to need physician help. And then even the physician may have a tough time. And he may say, in your particular case, with the kind of breasts you have, we have to do mammograms, because we just can't feel properly. But anything that changes or that you are uncomfortable with, you ought to see your doctor.
What about male self-protection?
There we come back to smoking again. I think really, in terms of smokers, they need a chest x-ray every year. The other, I think there are no preventative or measures in terms of men self-examination. Certainly if they feel a lump, they should, of course, see their doctor. But in terms of lung cancer, it can be very subtle. Certainly they should see the doctor if they ever cough any blood. It's a more difficult type of cancer to treat, lung cancer is. I wanted to add something about cervical cancer. Regular checkups and regular pap smears once a year. If the cancer is detected on a pap smear, the chances of cure for that patient can be as high as 97% if it's gotten early enough. And that's one of the few cancers which can be detected early enough to almost guarantee a cure. In terms of lung cancer, that's a different story. We are not successful in curing many cancers of the lung. And the only way, or at least I feel very strongly about this, the only way we're going to cure lung cancer is by prevention and not by treatment.
Can I just add one thing? That, for as long as we're talking about males, certainly any new lump in the scrotum or on the testicle should bring the man in for a checkup immediately. Testicular cancer is not that uncommon, often painless, and usually presents just as a lump, just as a breast cancer would.
Janelle has alluded to fear, and so has Dr. Phillips. And I think that probably it's important at all points to try and allay fears where they should be allayed and to encourage people when they should be encouraged. One of the areas is the use of x-rays. Now, when it was found that x-rays, the excess use of x-rays, it really caused cancer, then all of us became very, very scared and cautious, and we thought, well, maybe we shouldn't even have regular dental x-rays. What is the moderate position? I'm sure there is a moderate position. What do you recommend to families in the use of x-rays? Dr. Kramer.
I think a lot of that depends on the individual patient and what risks they are at to go undiagnosed versus the risks of the radiation. Certainly a plain chest x-ray has very minimal radiation, and the risks are extraordinarily small. The press has made a lot of mammography, and perhaps rightly so, and the medical profession has changed the machinery involved to some extent. We're now giving fewer rads per dose and cutting down on the risks. But certainly a woman who is at high risk for breast cancer needs the mammography. We're looking at the chance of an early cure now versus possible damage 20 years from now. If we don't find that cancer now, that woman is not going to be around in 20 years to worry about what we did with the mammography. On the other hand, we certainly don't advocate every 6-month mammography when there's really no reason to do it. But a woman who is at high risk, meaning she's had a cancer of one breast and you're watching the other one, her mother had bilateral breast cancer, there's certain other things that we can go right down the line to say this woman is at high risk. It's well worth the small risk of the radiation to detect that cancer early.
Doctor,
So it really depends on who you're talking about.
And Dr. Phillips, do you have anything to say about radiation or about just regular X-rays?
No, I think Ken summarized that very well. And we do want to keep radiation down to a minimum. And certainly radiation, you get a fair amount of radiation with any kind of fluoroscopy that is performed for upper and lower intestinal examinations. And we just have to be careful. The amount of exposure has to be kept down.
What does radiation actually do in the cure of cancer? Is it understood why radiation can both cure and cause?
Well, ionizing radiation definitely damages cells, and it damages the very basic element of the cell. And we think certain changes take place. Most often when we're treating cancer, the change is such that the cells die. But normal cells in that area are going to die too. But at the periphery of the field, perhaps where the radiation is not great, or in areas where the oxygen is not high enough, because radiation needs a certain amount of oxygen to work, maybe we damage the cell without killing it, and change the structure of the cell and change the way it behaves and its growth patterns. It's not fully understood by any means, and why, again, the same dose in one person has no effect, the same dose in another person may have great effect. We do know, of course, that the cells in the body that turn over the fastest, namely the bone marrow and the GI tract, are more prone to be affected by radiation.
What does chemotherapy do that is different from radiation?
Well, if you point the X-ray machine at a part of the body, it certainly is effective in treating the cells in the area of its field. But if it's pointed here and you have a cancer and this cancer cell growing in this finger here, it's not going to do anything. But chemotherapy diffuses through the entire body. It's usually taken up, if it's taken by mouth, it's taken up by the bloodstream, put in the bloodstream and ends up in the cells. If it's given by injection, it's in the bloodstream already, and it goes throughout the entire body. Now, there are some minor exceptions to that. There's called a blood-brain barrier, whereby very little chemotherapy gets into the brain when given injection through the vein or taken by mouth. Some cancer medicines do this, but very few of them do. So that, but with that exception, chemotherapy gets to every part of the body, whereas radiation, unless it's total body irradiation, where the whole body is irradiated, and radiation will only go to that area that's treated, where the radiation machine is pointed. We know that after the bombing of the atomic bombs of Hiroshima and Nagasaki, that about 10 years later, the incidence of leukemia markedly rose, certain types of leukemia, and rose significantly. Then it fell off again, and the incidence of leukemia in those areas are now back to its previous incidence within relative terms. So that radiation, there's no question there is some risk to it, but the benefits of radiation in especially certain types of cancer, such as Hodgkin's disease, have cured many, many patients with Hodgkin's disease. So,
Lou has built our bridge and has moved us into a discussion of specific techniques to be used to attempt to cure cancer, and I think you've done an eloquent job defining two. And Dr. Kramer, a minute ago you mentioned that there were at least three major. Would you share with us the other treatments for cancer, other than those that Dr. Phillips has just discussed?
Well, the surgical is the
Yes.
first, and most skin tumors and easily accessible areas of the body would be treated with surgery, and certainly breast cancer falls into that category. If we can cut out the tumor, most of the time we do what's called a modified radical mastectomy, which means removing the breast and some of the nodes in the underarm region. That is often sufficient, and if we've detected it early enough, we may have a cure just from that procedure alone. Radiation we've heard about. That can be used either in conjunction with chemotherapy or surgery or by itself. The same is true for chemotherapy. Very often we use it in conjunction with other modalities. Sometimes, particularly in certain types of childhood tumors, the one I'm thinking about in particular is called a Wilms tumor. We use all three. We use surgery, radiation, and chemotherapy.
So sometimes it's confined to one, some two, and sometimes all three. I know you were anticipating the next question because it's become a controversy in the last year in this country, mostly through Mexico using it. And I bring up the question too because the state legislature in Idaho has just passed a law allowing its use, and that is the question of Laetrile to treat certain types of cancer, especially terminal. And it's very controversial, as I understand, and only a few states are permitting its use. And I really have a two-part question. What is this particular treatment, and what is your position? Do you think that it has any value in the treatment of cancer? Dr. Phillips, would you like to take that one?
Well, Laetrile is a substance that's derived from apricot pits. And a PhD, Dr. Ernst Krebs, Sr., discovered it in around 1920, so it's been around here a long time. It had also been utilized as an anti-cancer drug for at least 20 to 25 years. It is controversial. We've had no scientific proof that it is effective in terms of killing cancer cells. Now, I'll let Ken go on with this, but with several aspects of it. But what I'd like to say is that as long as we don't have a cure for cancer, we're going to have Laetriles or other types of substances that people are going to use in an effort to cure their cancer. If we had a cure, there wouldn't be any need for Laetrile or any other drug. And it's something that we'll always have to deal with. We're concerned about its use because there's now evidence that it can be poisonous and dangerous. There are several children who have died as a result of the use of Laetrile, and maybe many more adults, we don't know. It is extremely expensive, and that money is going into the pockets of a very few people. And we feel that we've got to advise our patients to the best of our knowledge as to whether it's effective or not. Now, certainly people will feel better if they use any drug that they're told is going to cure them. And you have to understand that aspect. Ken, did you want to elaborate on a few of those things?
I just want to say that none of the drugs that we use in standard chemotherapy are in the same category as Laetrile, in that all of our drugs have shown some efficacy in animal studies. Laetrile has not. And I'm concerned that when we legalize one drug that has never shown any effectiveness in the laboratory, that we've opened the door, and we're going to see a lot more of these kinds of drugs. And basically it boils down to a consumer protection issue. Do we want to go back to selling snake oil out of the back of a truck, or do we want to give up a certain amount of freedom of choice, if you will, which is a nice phrase that the Laetrile proponents use, to be protected from drugs that are not effective? And that's really the worry that I have. Certainly, we have seen patients who have lost their chance of cure from cancer or of reasonable remission because they neglected standard therapy and went to get Laetrile. even if we assume that Laetrile is harmless by itself, which, as John alluded to, may not be true, we've delayed, as we've been stressing all through this program, early detection, early treatment with proven methods is the way to go. And if we lose that chance, often we never get another one.
Janelle Berg.
There's so many questions one would like to ask you, but one that comes to my mind is we sometimes hear about the discomforts caused by certain methods of treatment. How do you advise your patients and their family as to the discomforts that might accompany a chemotherapy or radiation treatment? Is it worth the discomfort you're going to have in order to prolong your life?
Most of the discomfort from chemotherapy is nausea and vomiting. Very often that's only on the day of administration of the agent. Very often it's preventable by use of antiemetic or anti-nausea medication, which we often give right with the chemotherapy.
I think this is a part of eliminating that fear that we have about treatment. A second area of fear that we often have is with the escalating costs of medical care. How does one go about paying for the kind of treatment that they may need if they have something as serious as cancer?
Oh, that's a tough one.
Does the American Cancer Society help in some way in this area?
No, they can help transport the patient to and from the doctor. They can help in giving the patient advice as to where treatment centers are. They can give information, but they cannot help in terms of financial aid. And most of their money goes into supporting research, but they also have a strong obligation in informing the public as best they can as to any aspect of cancer and providing information for them, but they can't help them financially. That is a tough one, and I don't think there's a doctor in the United States who does not support some type of catastrophic insurance program for everyone. Even though the cost of medicine is astronomical, most people can cope with a brief illness and deal with it financially. But when they've got a catastrophic illness, and that doesn't include only cancer, it can include a stroke that requires tremendous amount of physical rehabilitation and physical therapy, other types of illness. If there was some type of catastrophic illness insurance, I think that everybody would be happier. But I don't have an answer for that other than that.
Lou Reed.
Continuing on the subject of money, millions of dollars go into cancer research every year, both from the American Cancer Society and from other foundations and governmental sources. Do you both feel that the research is currently going in the way you would like to have it going? Are they concentrating in areas that you feel are going to be most helpful to your patients, or are there some tangents? Who wants to comment?
I'll start out by saying that a misconception is that you can legislate a cure, and that the amount of money is not necessarily as important as to where it's going, as you implied. I wish I knew where it ought to be going. It may be a discovery in some field, not even within medicine, that could open the door. My own philosophy is that one of the reasons that it's taking so long to get, quote, cures for cancer is that we're really talking about mechanisms of how cells behave. And that gets awfully close to secrets of life and how basic molecules interact. And that's a field that needs a lot of research, and not just by medical people, but by basic scientists. And I think it's a terrible job to have to decide who you're going to give the money to.
Well, where is the money going right now? What is the emphasis?
Going to many of the universities and medical schools that are doing basic research in cancer and in the National Cancer Institute. But as Ted says, you can't legislate research. If a person comes on to some lead, he's got to follow that lead. And it is not totally scientific. A lot of discoveries are discovered by serendipity, by chance, by luck. And they come upon some object of a research project which they hadn't calculated on, but they had enough time and enough money to follow that clue out to its end. It may not have been totally different what they started out to do. And we're not going to have a front page of the morning paper come out and say, a cure for cancer is discovered. Cancer, there are too many aspects of cancer that are different. We think there are many elements in the cause of cancer. And so there's not going to be one single cure. I wish there were, but I don't see it.
A lot of research is also being done to make sure that the different products and substances are safe and that they are not carcinogenic. Do you have faith in the methods that the Food and Drug Administration and the EPA are using right now to ensure that these products are safe? Or do you think that the American public is being bombarded with a lot of chemicals that have not been proven to be safe?
That's a complicated question, but the United States, the people in the United States, in terms of drugs, are much safer than anywhere else in the world. The Federal Drug Administration does a pretty good job in screening drugs before the American public is given those drugs. I'm sure the saccharin controversy, that was a law that was passed by Congress, and the FDA was only following what Congress wanted them to do. And you can't blame the FDA for that. That was written into the law. There are many aspects. There are many drugs that are tested elsewhere in the world that finally